Our team has chosen patients with heart failure in critical care unit. Heart failure is one of the biggest problems, and according to the Framingham Heart Study, it affects 1 in 5 adults. In a typical system, different streams of data is collected from bedside monitors, and it's up to the doctors to analyze all this information and make decisions. But the problem is that medical professionals do not have availability to monitor those patients on a continual basis. So if you ask them what's happening with the patient for the last minute or for the last 5 minutes, they cannot tell because they cannot observe or check patient's condition every single minute. Thus, as a team, we are recognizing a great opportunity for improvement in current critical care unit environment. Our goal is to build a system which will predict any subtle changes or potential anomalies 24 hours before it happens. That way, medical professionals could intervene earlier, slow the progression of heart failure, or prevent any adverse outcomes.
There are several important groups of stakeholders for our project. First and foremost, the patients themselves and those patients' friends and families. They have no real responsibility towards the system, and are primarily concerned with the medical benefits it provides. That is, a quick diagnosis and prevention of any life-threatening conditions. Doctors and nurses form another key group of stakeholders as users of the system. Unlike patients, they do have a responsibility to use it correctly, and so are primarily interested that it is easy to read and interact with. Funding to develop our system, bring it into intensive care units, and train doctors and nurses to use it ultimately comes from the sponsors and from the heads of the ICUs. This means that they have a responsibility to provide good value for money in terms of medical benefits, and an interest that they receive a significant return on their investment.
I am going to talk about what our system requires. The requirement of our system is divided into two parts. One is functional and the other non-functional. There are some kind of functional part. To collect the detected data through the sensor and to store the data into the database. To analyze the stored database using machine learning and data mining techniques, and to let the user access to the system via web service. On the other hand, there are some kind of non-functional part. To construct user-friendly UI. To encrypt the data in the system in order to avoid its access to the private information from non-authorized users.
Our team offers software and hardware solutions to healthcare services, including hospitals, specifically concerning problems which arise in a critical care domain. Our system provides utilities for constant monitoring of patients and logging all information into data warehouses. As this project involves huge amount of data, we decided to use big data approach. Here is a diagram that shows big data architecture that covers four main logical layers, which are consumption layer, analysis layer, data messaging and storage layer, and big data source layer. Whatever type of big data technology our group is going to deploy, there are key criteria that should be considered to ensure that it will provide with an effective framework for big data analysis. Four main criteria that must be taken into account are as follows: data accuracy, storage speed, quality performance, and scalability. There exist various technology solutions for handling big data, from open source to proprietary. Currently, the prevailing big data technologies are Apache, Hadoop, and NoSQL databases. Hadoop is an open source framework which is chosen as a target platform because it provides with high performance, scalability, and relatively low cost for handling big data. It has two components such as HDFS, which is Hadoop Distributed File System, and MapReduce. On the next slide there is a table which shows software, hardware, and services. We propose buying commercially available modules as long as they satisfy our requirements to keep development time and cost as well as maintenance overhead down, and build whatever is not available in the glue code to integrate the modules into the final product.
This is a Gantt chart of our development plan. We expect the project to take 3 years. The first 3 months are for acquiring and setting up all the hardware and developing a skeleton system. After that's done, while we get EC approval from the MHRA, we will complete the data collection and storage modules based on initial expectations, and then proceed with developing the analysis model. We start user testing the major revisions after the initial UI is complete, and testing the actual patient data after 2 rounds of user testing. We finalize the UI UX near the end of the second year, and then proceed into the support phase and actually trialing the benefits of the system. We will adopt an agile methodology with 2-week sprints. Stakeholders will be involved in pre-sprint planning sessions and in daily stand-ups if they feel the need to follow up. The system is quite complicated. Initial vertical slice deployments are not expected to be fully functional or integrated until at least a few sprints in, but such deployments shall be the objective measure of progress. Development environment shall be partitioned into 3: the daily test environment for deployment by the CI tool, the system test environment for end of sprint deployments, and the production environment, which is the current latest build that passes all tests.
One of the main concerns of our stakeholders is the value of the project, which implies the benefit they can get from their investment. So, we apply cost-benefit analysis to our proposal. We estimate the technical cost of our project in accordance to 4 main parts: system costs, data administration, application development, and training, to meet the requirements of a number of 8-bed units. The total estimated technology cost is £65,200. While the technical costs can be done with reasonable accuracy, it is more difficult to make an estimation of the project's benefit. We will record in detail the effect of our system on the ICU by keeping a close eye on each of the following metrics, such as average length of stay of patients in the ICU and mortality rate for patients admitted to the ICU. Then, we conservatively estimate the benefit that a hospital can get from their investment as £40,000 in the first year and £50,000 in the next 2 years. Through CBA, we can see the project would end up with a return of investment of £74,800, and hospital would get their payback after 18 months. We further apply net present value to our CBA, giving a deeper insight of the project value.